So now that we've established obesity as a disease, and we've also covered the data collection and evaluation and assessment part of the obesity algorithm, now when we're working with our client or our patient with obesity, now we're into the what do we do stage. Okay, how do we work with that patient? Now that we have the information we need to move forward, or some of the information, how do we work that with that patient to help them change the behaviors that or access the strategies that are going to help them, achieve a weight that is going to allow them to live their best life. And before we get there, I think it's leading from that last comment, it's important to talk about this concept of best weight. I love this concept. So this is kind of by the two big names in obesity here in Canada, Yanni Friedhoff and Arya Sharma. And this book, excellent book to pick up, speaks a lot to how do we manage obesity in a clinical setting, a practical guide to office-based obesity management. But one of the things I love about this book is that it talks about this concept of best weight. Okay, so they say a patient's best weight is therefore whatever weight they achieve while living the healthiest lifestyle they can truly enjoy. We often focus on a number and we say, oh, my best weight is 100 and whatever pounds. Okay, that's a number. And chances are that if you achieve that number in the head, or someone achieves that number in the head, there's a good chance that not everything about their life might be that healthy. So sometimes we achieve that weight through very unhealthy physical practices or very unhealthy psychological practices. So we want to make sure that whatever someone's best weight is, it's a weight where they can still live their lives, they can still be happy, they can still eat cake at a birthday party if they want to, and they can still truly enjoy their lives. Because if we get someone to a weight and they hate their life, are we doing good? Is that really good work? Okay, I love this next part. There comes a point when a person cannot simply eat less or exercise more and still like their lives. And I am definitely a testament to that as well. Because whenever I was at the weight that, let's say, I thought was ideal, and it was never good enough in my books, I was never happy emotionally or mentally or socially for that matter. And right now I believe very much that I'm at my best weight because I'm eating well and I'm exercising and I've never been mentally healthier, and this size might not be an ideal number, but it's best for me. Do you know what I'm saying? So this is something we can work with our clients with to figure out, to reframe what their understanding of their best weight is, because we have to be realistic too. If someone is 300 pounds, someone is 400 pounds or more, the chances of them getting down to, their ideal size, the ideal number they have in their mind, and looking good in a bikini and board shorts, whatever, as far as kind of that societal standard of what it is to look good, that's maybe not accessible to them. Just straight up, it might not be accessible. I know there's the messages out there that, you can lose weight and fit into that bikini body by summer or whatever, but for some people, a lot of people, obesity fundamentally changes the body to make it that much more difficult to keep that weight off. And we have to keep that in mind. So let's reframe what we mean by best weight. Okay. And that's what this quote argues. Now coming back to that concept of motivational interviewing, which you would have seen in your BPK 340 class. And remember, motivational interviewing it's about, the practitioner talking less and the patient or the client, talking more. And it's really about that patient or that client, this counselor leading that patient or that client towards their own strategies, towards their own investment in themselves. Not this person saying, do these things. No, it's about leading that person to come up with what strategies are most realistic and worthwhile for them to pursue. Okay, but these are some things that can help in this motivational interviewing process. We call these the 5 A's of obesity, which again, I believe is from Obesity Canada too. I could be wrong, but anyways. So ask, assess, advise, agree, arrange, assist. Okay, so a great place to start is to ask. Is it okay if we talk about your weight? Because for some people, they are not ready to talk about it, and they have maybe a lot of trauma or negative experiences about talking with about their weight with other people, and they might not be there yet. Okay, so let's ask before we start telling them. Let's ask if it's even a topic of conversation we're ready to entertain. Okay, something else you want to do in the asking process is to explore this concept of readiness for change. So we would have again looked at readiness for change in PPK 340, and remember it's kind of a continuum of what stage of change a person might find themselves in. So in pre-contemplation, a person doesn't care about exercising more or eating less. They are happy with where they are. I don't want to change, leave me alone. That's pre-contemplation. Contemplation is where most people are at. Contemplation is like, yeah, I know I should quit smoking. Yeah, I know I should eat better, but I don't know how. And I know I should do it, but I don't know. Okay, that's contemplation. Okay, preparation is like, okay, time to make a difference. I'm going to get ready. I'm charging up. I'm ready to change, and I plan to take action in the very short time. Okay, maybe I'm prepared to take action today. Okay, that's preparation. Okay, but an action is actually the doing it stage. Okay, where you're eating well and exercising more, smoking less, etc. That's action. And then maintenance, arguably the hardest stage, is when that person has adopted those behaviors and it's about continuing those behaviors. Okay, but it's important to say that no matter what stage someone's at, they can relapse. And relapse is often just a part of the process. It's not linear. It's not like you get there and you're done. Okay, but sometimes people will be at maintenance and they'll stop doing their activities and they'll slip back into contemplation. Okay, and it should be clear that that's actually very normal. Okay, and that's something that we could talk with our people about too. Okay, the other thing is assess. Okay, so we talked a little bit about assessing EOSS, evidence staging system, to help figure it out. We could also assess eating behaviors, and we can look at certain things like how much a person's eating, how are they eating? Are they eating alone with other people? What's going on with their appetite regulation? Does it seem to be out of whack? What's their satiety patterns, their fullness patterns? How much are they actually consuming? Is a diet analysis necessary? Kind of depends on what we're working with. The emotional experience around food too. Okay, is there any examples of disordered eating behaviors, like eating in the absence of physical hunger? That's not necessarily disordered eating, but it can be if it's all the time. Eating and then restricting, is that part of kind of what's their relationship with food? This is all like, what's their relationship with food? How much are they eating? When? With who? In what circumstances? What's their emotional state? Is there any loss of control eating? We need to kind of figure out what the origin of the problem is. And I love how many things are on this list because it's different for everyone. One person's problem is not the same as someone else's problem. So let's figure out what's at the root of it. Okay. We can also assess some of the drivers of excess weight. So is there mental things going on? Are there mechanical things going on, mechanical disturbances that are impacting their ability to exercise, for instance? For instance, if they have osteoarthritis, we talked about how that can negatively impact someone's ability to even stand at the kitchen making food, for instance. Okay. Are there any metabolic problems, or is there anything else? They call this milieu, it's kind of this the extra stuff. Is there anything else that's driving their weight gain? Okay. Is it things that are locked into their ethnicity and culture, for instance? I've heard stories of people that said, my grandma told me I have to eat lots of fat because fat is really good for me. So everything is with creams and whatever else. Is there some cultural things that need to be debunked? Okay, or worked with. Okay, is socioeconomic status an issue? Is time management status an issue? We're not just going to do a checklist here, but let's start exploring. Get that person to talk. Lead them in the directions that can help us figure out, or for them to figure out, what is actually kind of holding them back from adopting the healthy behaviors that can help them achieve their best weight. Okay. So when it comes to agree, arrange, and assist, this is all about helping them figure out what's going to be the best protocol for them. This slide gives a basic overview of some potential messages that speak to the dietary prescription, physical activity prescription, and behavior therapy prescription. I'm a little cautious presenting this because although it is based on evidence, I firmly believe that everyone's a bit different. That said, I think it's important to have some guidelines to look at. Okay, so this is key components of a comprehensive lifestyle modification program that achieved and maintained a 7 to 10% weight loss at 1 year or more. Okay, so what I like about this information is more based on long-term weight strategies opposed to like a 6-week program. Okay, so notice that they divide their recommendations for weight loss to those for weight loss maintenance because they're not necessarily the same. Okay, and for instance, if we're working with in an intervention with a counselor, coach, etc., in-person contact might go down with weight loss maintenance or might be gone altogether, whereas we might need more frequent contact when someone is kind of in that intervention stage. Okay, could be group or individual, doesn't matter. Dietary prescription, I'm really cautious with this. I don't know how I feel about recommending this. But that said, if someone it kind of depends on who we're working with. If we're working with someone with obesity and weight loss is a very important thing because of, let's say, metabolic complications that they have, then yeah, the most important dietary factor we need to look at is the caloric nature of their diet. The number one thing that determines whether we're gaining fat mass or losing fat mass is energy balance. Are we in an energy surplus? We're eating more calories than we're burning. We're going to be gaining fat mass. Are we in an energy deficit? Are we eating fewer calories than we're burning? We're going to be losing fat mass and weight. Okay, so a low-calorie diet, that's kind of at the foundations of a nutritional approach to a heavier weight where weight loss is one of the goals. Okay, they do recommend a macronutrient breakdown. But this just kind of all falls within like basic dietary recommendations, like the acceptable macronutrient distribution ranges, although they're a little bit higher in fat and protein. Okay. They also recommend quite a bit of exercise, 180 minutes for weight loss and more than 200 to 300 minutes for weight loss maintenance. However, the American College of Sports Medicine actually recommends quite a bit more physical activity for clinically significant weight loss versus weight maintenance. So for clinically significant weight loss, and this is what the evidence shows, that it actually takes a lot of physical activity to promote clinically significant, so more than like a couple pounds. Okay, and I know that, again, a lot of you guys are in kin degrees, and of course physical activity is one of the best things we can possibly do for our health. When it comes to weight loss, you need a lot of it. It's important for weight loss because it's also increasing basal metabolic rate, improving psychological health, etc. But on its own, it takes quite a bit of exercise to promote clinically significant weight loss, and sometimes even more to promote weight maintenance. So I would actually bump up these numbers compared to what this 2011 paper suggests. Okay. They also recommend some behavior therapy strategies, but really, I'm just cautious to put a blanket on any of this stuff because it really depends on the individual. And that's why, again, we recommend this motivational interviewing based approach where we're actually working with a person to figure out what's realistic for them. What does best weight mean for them? What are their limitations right now? And what's actually going to help them feel good in their body, not just when they lose weight, but like today and tomorrow and after that, right? We want to make sure that whatever intervention we put through or work with them to help them adopt, is going to actually be relevant for them, enjoyable for them, and not contribute to any psychological harm, emotional harm, or physical harm as well. Okay? And which is very different than all the diets, etc., that we see out there, okay, which are very restrictive, very one-size-fits-all-y, and really don't talk to an individual's strengths or their potential limitations. Okay, but I wanted to give you something as far as, what are some of the foundational concepts with respect to weight loss if that is a goal for someone with individuals with obesity. In the next unit, we're going to talk about some of the things that can sabotage our best laid efforts and people's best laid efforts with respect to behavior change and obesity.